All right, let's dive into the abdominal wall. Now, we're not going to just list off a bunch of muscles and nerves like a textbook. No way. We're going to look at it for what it is, a really dynamic and, yeah, sometimes flawed piece of human engineering. The whole point here is to zero in on the high-yield anatomy that you absolutely have to know for your exams and for your clinical work. So, let's get right into it.
So, here's our game plan. We'll start by comparing the bony cage of the thorax to the muscular core of the abdomen. Then we'll get into the muscles themselves. After that, we'll map out the nerves and blood vessels, and then spend some quality time with the inguinal canal. And we'll wrap it all up with a clinical focus on hernias. Pretty straightforward. Okay, first things first. Let's talk about why the abdomen is designed the way it is. And really, to get it, you've got to compare it to its upstairs neighbor, the thorax.
And here's the core trade-off, right? You look at the thorax, and it's basically a fortress of bone. Ribs, sternum, its number one job is protection. Simple as that. But the abdomen, it makes a totally different choice. It gives up all that bony armor for something else. Incredible flexibility. I mean, this muscular design is the reason we can breathe deeply, digest a big meal, move around, you name it. It's all about dynamic function, not just rigid defense.
So you might be asking, if there's not a lot of bone, what's stopping everything from, well, falling out? That's where the muscles and the layers of fascia come into play. They are the real support system of your core.
Okay, these are your four big players. The first three, the external oblique, internal oblique, and the transversus abdominis. I want you to think of them like layers of plywood. Seriously, their fibers run in different directions, which gives the wall incredible strength. Then, of course, running right down the middle, you've got the rectus abdominis. That's your six-pack muscle, the powerhouse that lets you do a sit-up.
But what's really cool is what they do together. Yeah, individually they help you twist and bend, but as a team, they form this amazing muscular corset. And probably their most critical job is generating intra-abdominal pressure. Think about it. When you cough, sneeze, or lift something heavy, all these muscles contract at once. They create this rigid cylinder inside you that stabilizes your spine and keeps your organs safe. It's an incredible system.
All right, let's move on to the wiring and the plumbing of the abdominal wall. And this is super important because the nerves and blood vessels here aren't just thrown in randomly. Nope, they run in a very specific, and for any surgeon, a very critical anatomical plane.
And here it is. This is a huge takeaway, especially for anyone heading into surgery. The main neurovascular bundle, the nerves and arteries, is safely sandwiched right between the internal oblique and the transversus abdominis muscles. It's this neat, predictable, and protected layer. And knowing exactly where that plane is, well, it's absolutely vital if you're making an incision and want to avoid causing a lot of damage.
And while we're on the topic of nerves, let's talk dermatomes. Think of these three as your clinical GPS for the abdomen. For sure. T7, that's right at the xiphoid process. T10, the classic one, is at the umbilicus, the belly button. And L1 covers that inguinal or pubic region. You just have to memorize these. They are absolutely essential for figuring out spinal cord levels and for understanding referred pain.
And here is a perfect, textbook example of why this GPS matters so much. Appendicitis. The nerves that sense pain from the appendix itself, they feed back to the T10 spinal level. So, what does that mean? It means the patient's first symptom is this vague, dull pain right around their belly button, the T10 dermatome. It's only later, once the inflammation gets worse and starts irritating the actual lining of the abdominal wall, the parietal peritoneum, that the pain becomes sharp and moves to that classic spot in the right lower quadrant. Super cool, right? Okay, now we're getting to one of the most important and clinically relevant areas of the entire abdominal wall, the inguinal canal. I want you to think of it less as a simple structure and more as an anatomical compromise. It's a necessary passageway for sure, but it also creates a built-in weak spot. So the trip through this canal starts right here, at the deep inguinal ring. This is the in door. And the single most important landmark you need to lock in your brain is its relationship to the inferior epigastric vessels. The deep ring is always, and I mean always, lateral to these vessels. That is a fundamental rule of this anatomy, no exceptions. And if the deep ring is the indoor, the superficial inguinal ring is the outdoor. This is the exit. It's basically a little triangular hole in the aponeurosis of the external oblique muscle. That's just its big flat tendon. And this is the spot where things like the spermatic cord in males pop out of the abdominal wall. Now, this thing can seem complicated, but thinking of it as a simple box or a tunnel makes it so much easier to remember. So what are the four walls? The front wall, or anterior, is that external oblique aponeurosis. The back wall, posterior, is made of the transversalis fascia. The roof is formed by the arching fibers of the two muscles underneath the external oblique, the internal oblique, and transversus abdominis. And the floor? That's the sturdy inguinal ligament holding everything up. Front, back, roof, floor. Simple as that.
All right, we've built the wall, we've mapped its supply lines, we've found its weak point. Now for the clinical payoff. What happens when this whole system fails? Well, that brings us straight to hernias. But before we can really talk about the different types of hernias, we have to introduce one more critical landmark, Hesselbach's triangle. This is a specific spot on that posterior wall of the inguinal canal that's just, well, it's weaker. It doesn't have as much reinforcement, which makes it the go-to spot for direct inguinal hernias to bust through.
And you can bet you'll see these boundaries on an exam, so let's lock them in. Medially, you've got the edge of the rectus abdominis muscle. Inferiorly, it's the inguinal ligament again acting as the base. And laterally, this is the most important one, it's those inferior epigastric vessels. See? I told you they were the key to this whole region.
Okay, here's the showdown. And it all, and I mean all, comes down to that one landmark, the inferior epigastric vessels. An indirect hernia starts lateral to the vessels. It follows the natural path, going through the deep ring and down the whole canal. This is usually congenital, something you're born with, so you see it more in younger folks. A direct hernia, on the other hand, is an acquired weakness. It happens over time. It doesn't bother with the canal's entrance. It just bullies its way medial to the vessels, punching directly through the weak spot in Hesselbach's triangle. Direct, medial, simple.
So how does this actually help you in a clinic? Well, think about the path. An indirect hernia is following that pre-made track of the inguinal canal, right alongside the spermatic cord. So you might see it travel all the way down into the scrotum. A direct hernia, though, is just punching through the wall closer to the midline. It's more of a localized bulge, and it usually doesn't take that long trip. So yeah, the path it takes really does tell you the whole story.
Which brings us to a final thought. You look at this whole design, it has to be strong enough to protect our organs, but flexible enough to let us move and breathe. These weak points we've been talking about, like the inguinal canal, they're not really mistakes, are they? They show that the abdominal wall isn't some perfect, flawless structure. It's a brilliant evolutionary compromise, a trade-off between strength and function. Pretty amazing when you think about it.